This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. One of their most popular articles published is Dale Aver's white paper on strength training for the older adult. You've likely heard us talk about this paper, but it is a fundamental piece of work that I highly encourage y'all to read. This paper covers proper dosage, how to set intensity, and how to get your patients strong. You can find this resource for free and much more over at geriatricspt.org/SRP. That's geriatricspt.org/SRP. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hi there, Senior Rehab Podcast listeners. This is Avin KG.
And I'm Tali Spaceman.
And you're listening to SRP Rex.
Yay.
All right, so today we are going to be talking about an article that is straight from the geriatricspt.org/SRP link that you heard about in the intro of this episode, and it is one of the resources available to you as a listener of this podcast.
Nice.
So the article is called Management of Falls in Community-Dwelling Older Adults.
Yes.
Clinical Guidance Statement from the Academy of Geriatric Physical Therapy of the American Physical Therapy Association. It was published in 2015 in Physical Therapy Journal. It is an open source article, so anyone can see it at any time, but in case you have trouble finding it, a link to it will be in the show notes.
Okay, cool. Let's do it.
When I first started looking at this article, I was thinking to myself, what is a clinical guidance statement versus like a clinical practice guideline, which is something I'm a little more familiar with. Do you know the difference, Tali?
Words are hard. They say the same, no?
Okay, so it's kind of like, don't look at the notes.
No, I'm looking like what is the exact like
clinical guidance statement.
Okay.
Versus clinical practice guideline, a CPG.
I think the clinical practice guidelines are more a consensus and what people are tested on. Mm-hmm. And you look at me and say, and like, I'm gonna make you look like a fool.
No, I'm not. It's just because it's very clear you don't know what it is. And neither did I until I did some research. So. Oh,
it's fine.
No, Tali.
It's fine. I'm not insulted. Come on, teach me with some condescending remarks.
Okay, if you put it that way. Okay, so first let's talk about what a clinical practice guideline is. It is defined by the Institute of Medicine as statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. So it has two parts. One is the examination and assessment of the evidence and its strength done by a committee. And then the second part is a set of recommendations based on the exam and assessment, including identification of gaps in the literature to guide future research. So the American College of Physicians established this program to develop these clinical practice guidelines, or CPGs, in 1981. And as a rule, they've stated that all CPGs are considered invalid after 5 years after publication or once an update has been issued, whichever comes first.
That's boss.
I agree. Yeah.
Because a lot of time, if you have students or let's say you get to one of those discussions online of the guidelines and people come and say, yeah, those are the guidelines. But yeah, they were published 8 years ago. They were terrific for then. But not only society changed, we learn every day. We learn more. You know, the clinical guidelines for after an ACL repair are not the same that they were 15 years ago.
Truth. Yeah, I think that is you hit the nail on the head. And I'm really glad that they have implemented this into the fabric of the clinical practice guideline framework.
It's hitting a nail in the head is a good thing, right?
As opposed to like hitting your fingers as you're like holding the nail steady. You'd rather hit the nail on the head.
I know. It's just
okay. Are you playing the foreigner card right
yes!
now? I love it. I
know.
love it. I'm into it. Okay. Clinical practice guideline. The difference between that and a clinical guidance statement is that the CPG is a primary review of available evidence, and clinical guidance statements look at these different clinical practice guidelines and then do a similar sort of thing for those. So it's like another layer of consensus and deliberation based on the available evidence. I feel like it just layers and layers and layers.
People thought, what can I write about? Can I write about something new? No, let's write about something that also already exists.
Yeah, let's show our expert opinion on something that people already know about. But that being said, because there are so many clinical practice guidelines that are published, I think it's appreciated and needed. Especially, we'll see as we go through this clinical guidance statement, or CGS, how it can be very succinctly put together in a way that can be applicable in the clinic tomorrow.
Yeah, and it prevents things from becoming holy, or like, oh, we have to do that. No, we need to be critical about our profession. We need to be critical even about the people in our profession that are the most valued, and you look at them like, oh my God, whatever you say is phenomenal. No, you need to look and to have doubts.
Fully agree. Okay, so the authors, who are these folks and why should I listen to them? First, I'm just going to read the name and what school they're from. They're all professors of some variety at some PT school. Keith Avin is an assistant professor at Indiana University. Timothy Hanke is an associate professor at Midwestern University. Neva Kirk-sanchez is an associate professor and chair of the University of Miami. Christine McDonough is an assistant professor at the University of Pittsburgh. Tiffany Schubert is a faculty member at the Center for Aging and Health Geriatrics Fellowship Program at UNC Chapel Hill. Jason Hartage is an associate professor at Samuel Merritt University in Oakland, California. And last but not least is friend of the podcast, Greg Hartley, the assistant professor at the University of Miami, and he's the current president of the Academy of Geriatric Physical Therapy, which, full disclosure, is one of our sponsors. I felt like that was important to say.
It is important to say.
So the introduction starts by defining the difference between a clinical practice guideline versus a clinical guidance statement. They further explain the guidance statements, basically saying they, quote, include a discussion of areas of agreement and difference, the major recommendations, and the corresponding strength of the evidence and recommendation rating schemes, and a comparison of guideline methodologies. So, if you have any more questions about the difference between a clinical practice guideline and a clinical guidance statement, read this article in the introduction. They do a really nice way of putting it all together. If you still don't understand, I can't help you, and there's no hope. Thanks.
Bye.
Bye. All right. Next, they talk about how falls are common, expensive, deadly, and increasing.
We don't need to go over it. We go over it every month, at least once.
That was a summary of 4 paragraphs.
Oh, okay.
That one statement. So yeah, you're right. We got this. So it talks about the prevention of falls. Screening for the risk factors are within our scope of practice. They mentioned the CDC's STEADI toolkit, which there will be a link to in the show notes. And they will say that clinical practice guidelines have been developed by all sorts of brilliant, well-funded organizations for the assessment and prevention of falls in community-dwelling older adults. However, the downside of these is that they aren't really physical therapy specific. So this can impair our interpretation and application of these tools, hence this paper. So the objectives of this document are to identify and critically appraise available CPGs, synthesize the findings from the high-quality ones, summarize the clinically relevant recommendations, and report gaps in the evidence.
Cool.
Yeah. Another quote from the introduction. We expect that physical therapists will use this clinical guidance statement to guide clinical decision-making related to the screening and management of patients at risk for falls and ultimately to reduce unwarranted variation in clinical practice and improve health outcomes, which I think is a bold goal. But I mean, if it's going to happen, this is how it's going to happen. You down? You in?
Yeah, I'm down. I'm in. Let's do this.
Cool. Next is a section called Method.
Which is...
I don't know why it's singular.
Oh, it's only one method?
Apparently.
Maybe it was good enough.
But it sounds like a systematic review.
It's a good enough method.
Which...
We did it one way.
This is it. Method.
This is the way we do it. Whoever doesn't want to do it can leave.
Exactly. Okay, so this is how they figured the expert panel. First, they took members of the AGPT, and then they had a practice committee, and then they also had a subcommittee on evidence-based documents from this practice committee. And so they took these people plus a, quote, content matter expert, although I don't know who this person was. They don't really describe how they're chosen. And why? I don't know. Well, it's very poorly explained, and I'm just curious, and I want to know why and how and who.
It's a committee.
No. I'm cool with the subcommittee
with the
and the committee. It's the content matter expert. Like, who is this Yahoo? I'm sure they're very prestigious and smart and all that, but
yeah.
But why was it necessary to have a content matter expert on the panel?
I don't know why I can't explain it, but I can see why.
So,
if any of the listeners can help me.
So they also had a coordinator. Well, okay, so I can see why they would need a coordinator. They would need someone to oversee the process to make sure that people stayed on task and like weren't going off the rails talking about silly things like grammar.
Of all the people that I know, you are the person that I thought the least would judge people for having a coordinator. You're my coordinator.
That's true. I do like to coordinate. I love organizing.
You're just jealous that you're not the coordinator.
A little bit. Please don't tell. So everyone on this panel was a physical therapist, and they had lots of different backgrounds, including neurology and all sorts of fun things. But not everyone had clinical practice experience with community-dwelling older adults. Their exact wording was that multiple panelists had clinical experience. Like, why this wording? And of those who didn't have clinical experience working with this population, what skills allowed them to take part in this committee? And, like, did they have research experience? Like, I just have questions on why they picked who they picked and the rationale for everything.
I think for the clinical guidelines, you don't need for making the clinical guidelines, you need people with background in research. For doing a statement, you actually, I think, want people that are more clinical background equipped.
Exactly. That's my thought too.
That because you want to see if those guidelines actually work in clinic.
Right. You need to make sure that these things are feasible. Talia's exactly correct. I don't know. Questions, no answers. It's fine. So then on to the identification and critical appraisal of guidelines. So there are apparently 11 clinical practice guideline databases, which I didn't know, but they used the terms falls, geriatric, and older adults. They did not use the terms elderly or senior. I know that the shift in terminology is relatively new, but these have been coming out since the early 80s. Or maybe it's because they automatically expire, they don't bother. I'm just not sure why they picked those three terms and only those three terms. Any thoughts?
Just because it's what we said about remember that you did the episode where the Academy of Geriatrics is not going to publish anything that has words like elderly or senior.
Right, but that was in 2017.
Yes, and yes, I agree that they're losing a lot of research if they're saying, oh, in 94 this was published, but it says senior. Yeah, it's a. Remember that I said there's a problem with the over politically correctness?
Yeah, I'm with you there.
This is one of them.
Oh, it is. Oh, okay. You were waiting for this, weren't you?
I was.
So they only included clinical practice guidelines from 2000 through 2013 in the English language in the correct population. But then it made me think about that whole expiration of facts concept. So now in 2018, does that mean that only clinical practice guidelines from 2012 are technically valid? Or what's the deal with that? What am I supposed to believe? Yeah, you can tell I go back and forth with this expiration date versus being really thorough issue a lot.
There's that.
Yeah. Okay. They said in the literature there were some issues with the definition of what a fall is, specifically whether the person had a loss of consciousness versus no loss of consciousness. But I've always heard it's an unintentional
encounter with the floor.
Or a lower surface.
It depends. Some people would say that it's an unintentional
lowering of the center of mass.
Yeah, lowering of the center of mass.
Yeah.
Which, again, those are very unnecessary words to say something and sound like you're sophisticated.
Your center of mass. I mean, it's descriptive. I'll give it that.
It is.
Yeah.
So what definition they went with?
They actually just included all of them. And then they only looked at community dwelling. Oh, so their issue with the definition of community dwelling was that there are different levels of independence in some assisted living residencies. So they basically excluded acute care, skilled nursing facility, long-term care settings, and people with specific neurological conditions and any sort of fracture management setting.
But they included nursing homes?
I think I don't know what they decided, but they just said it was problematic because of that.
The whole concept of community is like saying community dwelling is a little tricky.
That's true, because technically a nursing home is a community.
Yeah.
The hospital is a community. All right, so their search yielded 4,027 evidence-based documents. Out of these 4,000, 5 met the inclusion criteria.
Out of how many? 5?
4,027 to 5. They took out anything that wasn't a clinical practice guideline. So that took out a bunch. And then like incorrect population, people didn't fall, etc.
That's what happens when you have a method and not methods.
Yes. Method. So then they...
I just went through everything in PubMed. What's the difference?
Check. Method. All right. And so then they looked at these CPGs using the Agree To tool, which it's called the Appraisal of Guidelines, Research and Evaluation in Europe 2. It was developed to address the variability in guideline quality and to assess methodological rigor and transparency in which a guideline is developed. It's a really well-known tool, translated into a bunch of different languages. It's free to use. You have to get training, but all of the authors that were reviewing did this training. They look at things like the scope or purpose of the guideline, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. There's also a question saying, I would recommend this guideline for use, and you can answer yes or no and elaborate. So everyone used the tool for at least 2 reviews, and then at least 3 reviewers used it for the rest of them. And then they all had meetings to discuss and come to some consensus about any discrepancies in the scores greater than 2 points.
Okay, and it's not complicated because they only had 5 reviews to review.
That's true. Only 5. So then...
I'm afraid he's going to take the money away from the podcast.
Please don't.
Please don't.
We really need that money.
We spread knowledge and sometimes humor and
Method.
and the world needs humor and knowledge.
Very true. So then, after all of that, they developed 4 total drafts of the document. The first draft, they had a consulting group look at it, which was a physical therapist with expertise in falls, 2 lay people, or members of the population in question, physician, geriatrician, and an exercise physiologist with exercise in falls in community-dwelling older adults. Again, no words about how these people were chosen or their rationale for like all these seem like relevant people to ask.
I don't see a problem with how those people was chosen. In every review that you read or any article, do they tell you how they chose the people?
They tell you how they choose the subjects.
Subjects, yeah, but not the reviewers.
But these reviewers are making very big decisions about this document that can affect clinical practice for thousands of people. Like, why are these people the ones that decide? I see your point. Like, and a lot of times, like, they don't specifically say why they choose the people that they do.
I'm not bothered by it that much. I see that it bothers you.
Yes.
I see your pain, and I acknowledge it. My therapist told me to say that.
All right. So then there was an external review group, a bunch of people. Oh, God. Okay, this is the one that actually really bothered me. There were 2.
Okay.
The first bunch of people I'm on board with. There are 2 physical therapists that are geriatric clinical specialists. There's one who's a certified exercise expert for the older adult. There's a public health policymaker. And then this last one was, quote, special reviewers with specific expertise.
Yeah, why don't they say the expertise?
Right? Like, is this just your neighbor or is it your dog? Who are these people with their specific expertise?
It's not a dog, though it would be awesome.
A dog could be a special reviewer with specific expertise in pooping and chasing things.
You're obviously a cat lady.
Yeah. I don't know what dogs do. My cat has specific expertise in snuggling and making lots of hair and barfing in the middle of the night.
Well, I would love to hear his review, but...
He's also really dumb.
Yeah, what expertise or in what field? It doesn't need to be like...
A special reviewer?
And he makes a mean frittata.
Right. That could be a special review. That could be their expertise. They could have cooked for this committee of people. So then the third draft, every member of the Academy of Geriatric Physical Therapy could comment. And then there was the final draft, which was submitted to the journal.
Okay.
All right. That's it for the method. On to the results.
Yes, please.
Okay. 3 clinical practice guidelines were recommended for use. The first one was developed by the National Collaborating Center for Nursing and Supportive Care and funded by the National Institute of Health and Care Excellence, or NICE.
Aw, that's nice.
Yeah.
Did you see what I did there?
I saw what you did. It was perfect. Yes. So it's called Falls in Older People, Assessing Risk and Prevention. In the paper, it says it was updated in June 2013, but on the website, they reviewed the evidence in January 2016 and found nothing that changed the recommendations. So I think people are every year checking in on this.
Yeah, are we still okay with not letting old people fall? Yes. Okay, good.
Are the recommendations for helping them not fall good? Okay, yes. The second one is the American Geriatric Society and British Geriatric Society Clinical Practice Guideline, which was revised in 2010. If we're going by that 5-year rule, it is already obsolete. But they read it and recommended it for use. The third one is called Evidence-Based Guidelines for the Secondary Prevention of Falls in Older Adults. It was published in 2003 and it has not been revised. So it was by far the weakest one when it comes to the quality of the clinical practice guidelines.
Yeah.
Then there were 2 that were not recommended for use. We're not even going there. They're worthless. Don't pay attention to them. So then they do a synthesis of the strength and recommendations. There are tables. I'm not going to read you how strong the evidence is because they're not going to recommend it if it's not appropriately strong. So let's get on to the nitty gritty and the things that we can actually use. Mm-hmm. So they recommend, first they make recommendations specifically about screening. They state every year, everyone over 65 should undergo a falls risk screening.
Who does that fall risk screening?
We can, physicians can. It's within our scope of practice.
Nurses.
I don't know if nurses can. I would ask a nurse.
Okay.
This screening needs to include a report of falls in the previous 12 months, and they need to ask about the person's perception of difficulty with balance or walking. And if they perceive that they have some sort of difficulty, we should use our super awesome PT eyes to observe for balance or gait impairments. And they suggest things like using the TUG, the Berg Balance Scale, and the Performance-Oriented Mobility Assessment as options, but they state that any test that looks at balance, gait, or both is fine. A positive screen is if a patient reports multiple falls in the previous 12 months, or the patient reports one fall and a balance or gait impairment is noted. A negative screen is if they've only had one fall and they have no difficulty with balance or gait.
Okay.
Pretty simple, cuts right to it. I think it's something that you, as the listener, could take and do like a falls risk screening. Yeah. Fair.
Yeah, once a year.
Do a tug, ask them if they have the previous falls, etc. The authors do mention that the clinical practice guidelines do not address the situation of having obvious gait or balance impairments without falls. So I guess just don't worry about it.
Yeah, maybe because
if they're not falling, then we see that there's an obvious impairment, but it's not putting them at risk for falls.
Yeah.
Or at least not yet.
Which is hard for us to perceive because
I just want to fix everything.
We're like, oh my God, an abnormal gait. And you know what? What gait is normal?
Mine. Yours. Dustin's.
Is it? You saw me walk.
You're an assertive walker.
I am.
You get places fast.
I get places.
You and me both. We're like very
the places
assertive.
You'll go.
My mom gave me that when I graduated college.
Of course, because you're American.
Duh. I think I have like 3 of those books, actually.
Of course. I got the pop-up version of it.
Stop it. There's a pop-up version?
From my brother and sister when I turned 26.
That's phenomenal. All right. Then they make recommendations for assessment. So I'm just going to read straight. They have this in like a really nice, I think it's a figure 2, summary of action statements. Physical therapists should provide an individualized assessment within the scope of PT practice that contributes to a multifactorial assessment of falls and fall risk. Additional potential risk factors may need to be addressed by the appropriate provider as indicated. This assessment should include medication review with emphasis on polypharmacy and psychoactive drugs, medical history with emphasis on new or unmanaged risk factors, including osteoporosis, depression, cardiac disease, including signs or symptoms of cardioinhibitory carotid sinus hypersensitivity, and body functions and structures, activity and participation, environmental factors, and personal factors. And they give a list of 11, which I will read to you. So this is, ICF model.
11 what?
There are 11 body functions and structures, activity and participation, environmental factors, and personal factors that we should consider when doing an individualized assessment with a person that we have already screened and determined is at risk for falls.
All right. Number 1.
Strength.
Number 2.
Balance.
Number 3.
Gait.
4.
ADLs.
5.
Footwear.
Ooh. 6.
Environmental hazards.
7.
Cognition.
8.
Neurological function.
9.
Cardiac function, including postural hypotension.
10.
Vision.
And last and not least, 11.
Urinary incontinence.
Of course, it's the last one.
Of course it is.
And it's definitely not the least.
Definitely not.
Why did they say urinary incontinence and not incontinence at all? Because fecal incontinence is not a risk?
That's a really good question. I'm not sure. I think we would have to look back in the specific clinical practice guideline that suggested it, which they're all in those tables that I was telling you about, listed by the guideline that recommends them and the strength of the evidence in that guideline of that suggestion. So it's probably there. I might take notes on it.
All right.
But that's a really good question.
Thank you.
Maybe one of...
Yeah, sometimes I ask smart questions about poop.
Woo! Poop. All right. So then, lastly, so we have screening, we have assessment, and now we have interventions. So, physical therapists must provide individualized interventions that address all positive risk factors within the scope of PT practice. Components of the intervention should include, and there are 5 things.
1.
Strength training that is individually prescribed, monitored, and adjusted.
2.
Balance training that is individually prescribed, monitored, and adjusted.
3.
Gait training.
Not,
Just gait training.
Okay. 4.
Correction of environmental hazards.
5.
Correction of footwear or structural impairments of the feet.
Okay, so it's about correction and about working with the patient.
Yeah, and footwear shows up twice in there, like in interventions and assessment.
Usually it's slippers,
Flip-flops,
Crocs.
I mean, surgeons wear Crocs.
Yes, but they wear it only in the hospital.
All right, so that was figure 2. Figure 3. It is a flow chart of all these things that we were just talking about. So it starts with an older person encounters a physical therapist.
That's how everything starts.
Exactly. Yeah, it's like real life. Either the PT asks the person whether they have fallen or have difficulty in balance or walking, or the PT observes a balance and mobility impairment. You just follow the arrow. Conduct a screening. Negative screening, continue usual care. Impairment noted, on to the next one, on to the assessment. And then, you can refer to the appropriate healthcare provider. If there are risks that are identified between the scope of PT practice, you intervene. So the flowchart is really succinct and beautiful and puts everything right in one place that you can take with you, like I said, to the clinic tomorrow and start using.
To the clinic!
To the clinic! All right. So that's it for the results. Anything before we go on to the discussion?
So we have the 5 things that should be corrected or worked on.
Yes.
And the 11 risk factors.
Well, the 11...
Or not risk factors, but body functions and structures that need to be screened or examined.
So it might be better to think about it so it's screening, assessment, intervention. In the screening, that's where you're going to ask about history of falls, and you're either going to hear about or observe a balance or gait impairment. The assessment, you're going to ask about 3 general things. 1, medication review. 2, medical history. And then 3 is when you're going to do the ICF model assessment.
Perfect.
Yeah, so the ICF model is embedded in the assessment, but it's not all of it.
Yeah.
And then you have the things that are within the scope of PT practice that we can intervene on, and that can be very effective in helping prevent falls. And that's the 5 things.
All right. Bring us home.
Okay, so in the discussion, they talk about how there are common recommendations across all 3 of the recommended CPGs. 1, all older adults should be screened for fall risk by asking questions about falls and difficulties in gait and balance. 2, a positive screening should prompt a comprehensive multidisciplinary fall risk assessment. And 3, a multifactorial assessment should be followed by an intervention to address identified risk factors. So that's pretty much what we just went over with that flowchart. It's like you wrote the discussion, Tolly. I love it.
Aw.
So then they took these recommendations
It's like I listened to what you said.
Oh, thank you.
It's almost like I was here just listening to Erin speak.
So then they compared these recommendations to the U.S. Preventive Service Task Force recommendations, which are used for Medicare reimbursement. So they're similar. However, the recommendations in this paper are more specific to PT. So there are limitations such as the population didn't have any neurological issues, they didn't look at all the settings, and they maybe didn't find all the clinical practice guidelines, which I'm glad they acknowledged. And this is interesting, no economic analysis of costs to society and things like that. I like it.
I like it, yes. Unfortunately, money is something that we need to think about always, because
everything takes money. All right, so conclusions. Every older adult should be screened once per year for fall risk. Screening must consider balance impairment and gait and mobility limitations. We are just beating this dead horse. The screening may trigger a multifactorial risk assessment that can include consultation with other healthcare providers. Exercise is an effective component of a fall prevention program. Education about footwear and home hazards can also be included in the fall prevention program. Current recommendations are not specific enough for PTs, but this is a good start. And then gaps in the knowledge include programs for specific subpopulations of older adults, tools for PT assessment and intervention, and more evidence needed for specific exercise interventions. And that's what I have for this article.
You had a really good article.
Thanks to the Academy of Geriatric Physical Therapy for having this on their toolkit. You can see it right now if you go to geriatricspt.org/SRP.
Yeah, I like that it actually gives tools.
Yes.
Thank you very much for listening. I'm Tally Spaceman.
I'm Erin Carey.
And as always, stay funky.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.